Welcome to Kidney Cancer Unfiltered. I'm your host, Anna Maria Scaccia. In today's episode, we're joined by Dr. Pedro Barata to explore how where you live can affect your cancer care. We'll talk about the challenges people face in rural areas, the role of social workers, and how telemedicine can help bridge the gap. Dr. Barata also highlights the importance of building a supportive community, no matter where you are. Thanks for being here. Let's start the conversation. Well, thank you so much, Dr. Barata, for joining me today. For the listeners who may not know you, can you talk a little bit about your background?
Sure. Well, thanks, Anna Maria, for having me on your podcast. So I'm a GU oncologist. That means I'm a medical oncologist, and spend my time, researching and taking care of patients with kidney cancer as well as prostate cancer and a little bit of bladder cancer. So we call that GU tumors, right?
Okay.
Genitourinary tumors. But I dedicate my life mainly prostate kidney cancer. I try to be very involved in clinical trials, so bring
Okay.
novel therapies or approaches or strategies that are perhaps some of them not available to folks in the community. And we bring those studies with collaborations, efforts, cooperative groups, pharma partners, etc., and it's opportunities to get access to new treatments and new approaches, as I said. And that's what we're trying to do in Cleveland. So I work at university hospitals at Seidman Cancer Center, affiliated with Case Western Reserve University in Cleveland, Ohio. And before that, I spent a number of years at Tulane University at New Orleans. And originally trained in Lisbon, Portugal. So I've been in the US for now close to a decade, and but I spent my first part of my life on the other side of the ocean.
Well, thank you so much for that bit of background. I wanted to dig into what you had mentioned in terms of the communities you work with and bringing new treatments to them and access. So I think one thing we don't often talk about in cancer care in general is the access to the actual care. For me, I had access to big medical systems, two of them. Most of the survivors I know have access to MD Anderson or another big medical system like Vanderbilt. But there's a whole community out there living in like rural areas and small towns where the access to care isn't as easy, if you will. So I wanted you to talk a little bit about the most significant gaps and or challenges in, the current like oncology care, if you will.
Right. Yeah. No, what a thoughtful question, and I guess I can address that in many different ways. Let's start by saying I couldn't agree with you more. It's quite interesting to me that the way the health system is structured in US. It's interesting because it does depend a lot where you live.
Yeah.
In general, if I were to summarize for the listeners, we have places where, you have teaching responsibilities. In general, you might be associated to some kind of school, medical
Hmm.
school, others. We usually call those folks academic folks,
Hmm.
which is different from community, often associated to private practice. But you also have certain systems that are separated from these ones, like the VA, also have teaching responsibilities, for example, and or city hospitals, for example, who have a safety net for folks who might not have insurance,
Yeah.
and they're able to get their care there. So the care can be delivered in a very different way. Of all these buildings and all in the system, you can find standard of care approach. What that means is treatments, approaches that are approved for patients with cancer based on data that have shown that doing that it helps them.
Hmm.
So that's that. And the standard of care changes over time, and it changes because you run clinical studies to ask questions for which we don't have answers. And then once we run the study and we got the answer, that can become a new standard of care. So the standard of
Okay.
care changes through clinical trials. So a simple way for me to summarize a clinical trial is to say, if you are part of a clinical trial, you are part of the medicine of the future, right?
Yeah.
If the trial is positive, then that will become then available to everyone. So the reason I'm bringing that up is because not all players that I describe in the system have the ability to run clinical studies,
Hmm.
offer those studies to patients, and so they get access to treatments of the future, as I called it, right?
Yeah.
So that's one part. The second part is, cancer care, and we're talking specifically about cancer. I hope it's okay, Ana Maria, but
Yes.
cancer care changes very, very quickly, and it has changed dramatically in the last few years. That that creates a lot of challenges to the providers. Why? Because you have to be up to speed with things at a pace that is very, very difficult to follow, particularly
Hmm.
if you treat many different diseases at the same time, right? So why is that a problem? Well, because the standard of care changes within a year or two with two, three novel, four different things, and you have to know about those. Otherwise, how come you're going to offer those new treatments to patients? So that's the other challenge, right? So depending where you practice, it can be more or less challenging to be up to speed with things just because of how the system is structured. So, and the last thing to your point is, how do you know what's going on out there for the cancer you were diagnosed with? And that is very difficult to answer. Some colleagues and some providers are very thoughtful and collegial, and they reach out to colleagues and there's a discussion within peers. In other cases, they're more isolated and there's not that environment. It's not happening to the same extent. So from that perspective, there is this disparity of care, if you will, that is really relevant and is certainly the case in New Orleans, in Louisiana, also in Ohio. You can get very different levels of care depending where you live.
Hmm.
Finding out information is not always easy because even if you go on Google or something like that, it doesn't necessarily mean that number one, you'll find the right information. Number two, you understand what's in there, right? And so that creates a new level of complexity. So to go back to your original question, I couldn't agree with you more. I think there's a lot of disparity. I think one way we can do there's a lot of ways we can do to
Yeah.
minimize that. And I predict you're probably going to ask me for that, but
Yes.
obviously one is awareness, right?
Yeah.
And things like the one you're doing. What are you doing right now? We are raising awareness for how the system works. What can we do to empower ourselves with information to search for the best care possible, I guess, for for the cancer we're dealing with or some our significant others dealing with.
Yeah. No, thank you for that answer. And I wanted to talk about the patient experience and go deeper into that because I'm thinking about situations in which someone has to drive 2 hours just to be able to get surgery because the hospital near them is too small to actually take care of their cancer, or they may not have an oncologist actually in their town. I don't know if people realize that oncologists are not, I don't want to say easy gets, but they're not easy to like, they're not always easy to find, especially particularly in like rural areas. You may not actually have one. So I wanted to get your insights into how that actually impacts treatment, right? We have the diagnosis, but then once you think about these challenges like travel, like do you actually have access to an oncologist? Like, do you have access to a hospital that can treat you? How does that impact someone actually getting their treatment?
Yeah, so fantastic question. So it's actually interesting because I'm flying back from Hawaii, and I just found out that some patients in some of the islands have to fly to get their care with
Mm,
an oncologist. And of course, when we think of US, mainly I think of the mainland, but it
mm,
was so eye-opening to me to think that, can you imagine you go through radiation therapy, through chemo, and you actually have to jump on a plane every 2 weeks, every 3 weeks, every week at times, to get that care. So that is an example, and there's many examples out there about that. And there's a number of challenges. I mean, I have many many patients who travel, and 1, 2, 3, 4, 6. I'll never forget my patient, driving 6 hours
mm,
to come and see me at Tulane in New Orleans. She lives in Alexandria, and she
mm,
came to see me, and stay with us. And how was that possible? Well, in those places were more remote. Partnerships, collaborations. So what we try to do, or at least try to do, is I go and get and try to meet the providers and the teams at each institution, sometimes more remote, and I take those opportunities to get to know them, drop my cell phone, my email, patients and myself, etc. So that helps to build a network of connection, then I'm available, for example, for a case. Let's discuss a case, and we jump on a call really quick and we go through a case and what can we do to help. Other times is about you might have an oncologist, but for certain tumors that are less frequent, you have to review the pathology, right? What
Yeah.
comes out of the biopsy of the surgery. Sometimes there's no expertise there. So it takes you a long time to send the tissue out just to find out the cancer you have. So
Yeah.
it's, even if you have the person, but then you need another colleague because you cannot practice oncology by yourself,
Yeah.
right? Because you are dependent on scans, you are dependent on pathology reports, results, because you need to treat the right thing. You need to know what you're treating and you need to know what it is. So these are just basic concepts, right?
Hmm.
And then, and I consider myself young. And if I were to repeat medical oncology again, fellowship again, I would learn 60 to 70% new stuff compared to when I trained. So that gives you an idea. If I'm isolated, treating many different cancers at the same day on the same day, it gives you an idea how difficult it is to be up to speed with all the novel technology, novel treatments that are available to patients today. So all of those are challenges, and of course, the more remote you got, and you might not have the means to actually
Yeah.
jump in a car on a plane, or I have some patients who fly to come to see me. Other patients drive. Most people drive, but I have some folks who actually live 5 minutes away. So it's quite different, right? And
Hmm.
I have patients who tell me 10 minutes away, not interested in trials, for example, and another ones who are actually taking 5 and 6 hours and are at our center every 6 hours, every week because they want to be in a specific study. And we try to accommodate. But the needs are so different that we do our best with involvement of social worker, involving, see what support the patient has to try to get the care they need there. A lot of times, when I think the treatments are the same, for example, I try to find a person that I trust local and I reach out, I call in front of the patient so they know we're talking, etc. And I find that person and then we chat, we do virtual visits or phone
Hmm.
visits to make sure things go well. But that's, for example, a way that we normally do to make sure patients can get access locally,
Yeah.
right? And for standard of care, that is possible. For trials, that's often not possible because trials run into particular sites that are approved to
Hmm.
run them. But for standard of care, definitely is, right? And when you go to a person who does just treats kidney cancer, for example, for a living, I think you'd go for two reasons, right? One, for the expertise, because it's not a cancer that you see every day. Number two, can you get access to treatments that are not available elsewhere,
Yeah.
right? And at least for one, you can work with the local teams to hopefully provide the best care possible to the patient that is seeking help.
Yeah. Well, you brought up not having the means. So I wanted to dig a little bit more into how socioeconomic factors impact both like treatment, prognosis, big city compared to remote areas. Because I'm thinking about people who like you said, may not be able to drive 6 hours to a bigger site to get access to a clinical trial, and maybe the clinical trial is the only thing that may work, right? So how do those socioeconomic factors impact that access to care and the outcomes?
Yeah. Well, they certainly and they impacted at different levels. For some patients, unfortunately, their social economic situation is so dramatic, if you will,
Hmm.
that their diagnosis of cancer is not their number one or number two or number three priority. They have other priorities like
Yeah.
eating, like having a shelter, and that's really challenging, right? So I happened to work, when I was down in New Orleans, I happened to work at UMC, and we had a number of patients that those were the priorities, not necessarily the cancer, right? And so it's eye-opening on one end, and unless you help to address that, you don't want to address priority number five if you have not the first four priorities addressed, right? And so recognizing the priorities is very, very important. So it can be cultural priorities as well, right? Like, I remember doing Mardi Gras, for example, in New Orleans. We had to adapt. It's very
Yeah.
difficult to get patients in for a number of reasons, because also culturally, that time of the year is very, very important. So you got to respect that, right? And I'm
Yeah.
sure Marika is just an example. We can do many others. So I think being aware of the priorities of a patient and exactly what they are, and addressing them, I think it's super important, right? Without that, treating the cancer doesn't make a lot of sense if that's not the priority. We have to be aligned, right? We can always help people who want help,
Yeah.
and we got to respect their wishes and their list of priorities. So that comes, that I see it that way, at
Yeah.
least, and then you have the patients that, yes, cancer the priority, but they still have those challenges.
Yeah.
I now work at a place where patients are insured. So, and things are different because if you go to the VA, it's a different environment than if you go to a place that takes uninsured patients versus a place who has commercial insurance, right? So that the needs can be different. I want to say that most of these places do have outstanding social workers and financial counselors that help us navigate the challenges that can come up. So
Hmm.
at UMC, often, we had the Office for Medicaid who was, just addressing that, and we needed that to provide treatments to patients when they were not admitted at the hospital, right? So having those teams available, it's critical. You cannot work without them. Again, you cannot treat cancer on your own. It's not you cannot open an office
Yeah.
lost in the world thinking that you're going to be successful or providing great care because you can't. It's not possible. You depend on it takes a village to take care of a patient with cancer. So having the social worker, having the financial counselor is super, super important for those patients, because all our treatments are very expensive. So,
Yeah.
so the needs are maybe different from what we think the needs are, that we think they might be. Often treatments cost thousands of dollars a month,
Yeah.
right? Very often, and so that puts a lot of pressure in the current situation in terms of our coverage, if you will.
Hmm.
And the other thing is, we can't assume, someone's wallet is the same for everybody, or the concept of what is, what is your wallet look like. So I don't ask those questions, but I try to be as respectful as I can, about, is this a problem? Is this going to be, do we need to help? Do we need to work on this? And I find those conversations super helpful. And most of the times, yes, we are successful at those. Maybe because we identified them, we were able to work together on that.
Yeah.
Fortunately, in Cleveland, where I work, the vast, 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 vast majority of the times, patients are able to get what I thought was the best treatment in the
Yeah.
world for them. And that's always like I like to think is like, as a provider, I like to think, what is the best treatment in the world for you?
Yeah.
And the second question is, can it happen? Can we make it happen for you? But I don't, I think it's important for a patient comes to ask for our thoughts, for us not to invert the order of the question,
Yeah.
right? Question number one should not be, can this patient afford it? I
Yeah.
think that should never come first unless the patient tells you, I don't want to talk about cancer before addressing the social or the economic situation. That's different. But I think if you asking me, Dr. Barata, what is the best treatment for me in the world? That's the right answers. Like clinically, do we know? And this is why. And then is, can we make that happen for you?
Yeah.
Let's find out. And sometimes I transfer the care. I talk to the teams in a different institution, like we did in New Orleans, for example, several times. We engage with the folks who are in network, who are able to see. So there are ways. And finally, sometimes there's this peer-to-peer,
Hmm.
which, even if you have coverage at times for certain treatments, it's not a guarantee they get approved. So you really need to have a care team available to talk to insurance and basically advocate for the patient with the patient's case. And it helps if you know the data. It helps if you document why you're asking for a treatment X for those patients, right? And finally, the distance. So for patients on standard of care, again, social work, financial work help a lot. For patients on clinical studies, we ask upfront for support based on distance, etc. So we have that planned. So when that's needed, we already have the budget for it. So we have a solution for it. So, for example, in New Orleans, all the time we had patients getting Lyft or Uber coming to Tulane for to go on trial, for example, right? So it's just an example. So there are challenges for sure, and there are all solutions. But I would argue rarely these can be solved by one person only.
Yeah. I'm glad you brought up the support for transportation and distance because that was going to be one of my questions about the challenges with transportation and its impact on receiving timely care and if there how can doctors in local communities help solve that for people who might have to go outside of their city to get that treatment. And
Right. Yeah, so it's not perfect. The system, depending where you are, does a good job or a better job or a great job. I'll explain why it's hard to be perfect. One of the reasons is if you have the transportation set up, let's say you're approved for it and you're going to have it. The challenge is this is not math. In other
yeah,
words, the treatments can be scheduled, but as you know, and things happen. You
yeah,
might get an infection. You might have to come in the office or the cancer center sooner than it planned. And oftentimes, the ability to accommodate those changes in the plan, saying you're not feeling good in the morning and you have to come and see me in an hour or two, not always you will have transportation set up for you to come. You need
mm,
time, you need a day or two or three in advance to set up that transportation. So it's not perfect, right? So I don't want to make it sound like there's no problem. There's definitely
yeah,
problems with that. Once it's set up, I think the systems, at least the ones that I've worked, I had, they were thoughtful enough to plan that as best as they could, and we try to plan ahead to basically come up with a plan B and plan C. So one easy thing, for example, is if there's something going on with you, you don't need to come to see me for urgency or emergency. You have my cell phone, you go to your
yeah,
local emergency room, and then I'll talk to them once you go there, right? So I
yeah,
always like to talk to the doctor emergency room because, I want to make sure he knows what I'm thinking that might be going on with you. Right. So that's an easy way. We can all do that. And probably that's going to solve the transportation issue if I'm 2 hours away from you, right? On that particular day. So that's an example where sometimes we can come up with, but certainly areas that are more remote, that problem is probably more obvious, right?
yeah,
A lot of areas in the United States where the closest cancer center is 2 hours away.
yeah.
And so I think it's something that there's all these grants. We apply for quality projects, we apply for grants, you know, and again, as part of these philanthropic support that we have from folks also that can be sent to support the folks who are more vulnerable.
Well, so a couple of times, in terms of support, a couple of times you've mentioned the use of like remote medicine, right? Virtual, like being virtual. Um, how can or is actually it's a two-part question. One, is telemedicine being leveraged more to get access, like to get that care to people in more remote areas? And if not, how do we increase the role of telemedicine? What is needed to make that happen?
Yeah, I think, well, we're certainly using it more than pre-COVID. And COVID was just the trigger
Yeah,
for us to start using it, right? And I think, and actually the systems adapted to it. And I think we are good within the same state. There are more challenges if you are out of state for coverage reasons, right?
yeah,
But at least within the state, that has been used a lot more. But as you can imagine, in certain cases, you have to drive to a different state or get to a different state to get your care. Not always, but sometimes you do. And then the other thing is, of course, the virtual technology and telemedicine, assumes that you have access to a camera and a computer
yeah,
or to a cell phone with a camera, which, sounds like everybody has one, but that's not quite true, right?
yeah,
And so actually, a lot of times I end up doing phone calls instead of tele visits, right?
yeah,
Like
yeah,
I omit the camera and just I'm on the phone. Now, as you can imagine, that works, but it's not ideal, right? You want to see
Yeah.
your doctor, you want to understand there's a nonverbal communication. A lot of times there's bad news, or you want to
Yeah.
have, conversations that are more challenging to have. How do you do those over the phone? So it helps. I don't think it can be the system can rely only on it, but it's definitely a tool that helps. And on the clinical trial setting, there's a project, for example, that is being leveraged as a pilot out of Florida, where they sit in Florida and they provide 24/7 the nurses support to places in California, you know,
Okay.
and that's via the telehealth system. And so patient can be enrolled in the community in California and still be on trial because he's being monitored, via telehealth with the team that's in California, that's in Florida. So there's definitely a tool that helps the standard of care. Also, I think it's starting to get included in some studies, clinical
Oh,
studies.
okay.
So that's encouraging, I think. I don't think it will solve all the problems. There's definitely a tool that can, and I think it still needs to be used more.
We talked about structural changes or supports in which the healthcare system and providers can give to meet these challenges or to address these challenges. But the communities themselves, like the communities that people live in,
Right.
I guess maybe their local providers and also their local survivor or patient community, what is their role in raising awareness and education and improving access to care?
Yeah. So that component of care, it's super, super important. It cannot be stressed out enough. The way I see it, at least, let's say I'm the patient with cancer. I go and see my doctor. There's a lot I don't know. I might read more or less. That's a lot I don't know, right? And I will trust my doctor will tell me, what I need to know about it. But it's never enough,
Yeah.
right? I have a lot of questions. There's a lot of uncertainties. There's a lot of knowledge being shared. There's a lot of information. I'm not going to understand all of it. I'm not going to capture all of it. And even if I do, I think I'll forget some by an hour later, 2 hours later, a week later, right?
Yeah.
So, and there's this uncertainty about the future, there are fears, there are concerns, etc. And so we have the tendency to share our stories with others, which can be incredibly helpful. But you can be on your own. But then if you find people who are going through the same journey as you are, you now have something in common, right? You can share those experiences and those emotions and what you're going through with that other person. And now imagine, instead of one person, now you met 10 people
Yeah.
or 20 people. And you will find within those 20 people, you're more likely going to find one that has exactly the situation very similar to yours. And out of the sudden, you start learning from talking to them, right?
Yeah.
And then imagine you have a group of 50 or 100 or 500 people, and they are actually so well organized that they actually start launching educational activities and actually get you to get closer to providers who treat the same cancer. And you can attend those if you want, and you get togethers, etc. So what I'm describing is a structure that can start with one person only.
Mm.
You expand it to a cancer community or a support group, and you can expand that to a patient advocacy group like kidney cancer, like KC
Yeah.
Cure, IKCS, etc. Right? So supports groups in general can be started at the institution, at the hospital. Sometimes they start by a patient who just is so dynamic and wants to do something, brings it up to me, hey, Dr. Barata, let's get a group together, right?
Yeah.
And it's like, I think that's a fantastic idea. And actually, that's how we did our Kidney Cancer Day in New
Mm.
Orleans, and Prostate Cancer Day, right? And you would ask, well, is there a need for it? Well, I can tell you, we had 70 to 80 people on our first Kidney Cancer Day ever in New Orleans. Never happened
Oh,
before,
yeah.
right? We had 100 people on our prostate cancer day for patients, for example, and so it's incredibly helpful. And people go online now, right? So
Yeah.
what I describe is a functional description, because there are physical groups, but you can also find them online on social media, right? In
Yeah.
many different ways. I often get emails from support groups say, hey, are you able to see a patient? Reach out to us. Lives not far from Cleveland. It's like, absolutely, we'll get them in right now, right? So
Mhm.
that happened in New Orleans. So those groups are so important because they, number one, they can give you knowledge. They can get you in touch with people who's going through similar journey as you are. You get access to providers who treat that cancer. You can ask questions that you might not feel comfortable asking your provider,
Mhm.
right? You can get more engaged and be an advocate yourself because now you know the community, the broad community, if you will. So we need more of that. And what I've found from going to different places here in the country, there's not that much. And there's definitely a need for it. So it's a call, sometimes all it takes is you bring it up in your visit with your provider, say, hey, how about we do this?
Yeah.
And I've seen many different groups starting like that. So that's a call to, don't get shy and is always helpful because we don't need to be alone. We're not alone. And I see so many advantages from having those groups structured,
Mhm.
those communities structured that we need to raise awareness and people know what they have available, sometimes close to them. They just don't know.
No, I think that's great. Community is powerful, and I think we hear a lot of stories of survivors who've connected with communities and were able to even find doctors to
Yeah.
take care of them because they couldn't find one locally. So wrapping up, because I know we're at time, I wanted to take going from that, like starting from awareness, what are some other ways in which we can solve this access to care challenge?
Yeah. So what do we do here in Cleveland to minimize that or to try to help, right? The nonprofit organization that I'm part of, right? They reach out to the local communities. We have a large African American community, so for them, barbershops are important, churches are important. So often we go out there and we meet them, we meet folks, and we talk about kidney cancer or prostate cancer, for example, right? And we get to talk about things in lay terms and we break it down. Other times in social media, so that's another one, right? Other times in New Orleans, I remember we had a PSA screening program for free, and they used to bring American football stars,
Oh, wow.
Saint stars, etc. So to actually attract folks who come, get some autographs and pictures, and they get screened, right? You can get a liaison, right? Someone who can connect you with the local communities right there to connect and to get together. So you can do it in different ways. So in Cleveland, we have done that. We've created, we've done New Orleans. We're trying to do this here. Put together patient dedicated events, um, right? So focus on patients and patients bring their family members educational sessions like once, twice, three times a year. We go and just talk about things and able to answer questions. So those are ways. Sometimes we go on the local show or local
Okay.
TV,
Yeah.
and we have 1 minute to talk about, that topic. So it's all about awareness, right? It's like,
Yeah.
and you address the myths, you address the concerns, you address the trauma, the drama, the questions, the insecurities, perhaps the bad stories that you have in your family that
Yeah.
happen, and you address all of that, right? And if you build trust by by knowledge, by addressing what's going on, and you explain why we do what we do, right? We want to help people. That's what we do.
Yeah.
We help, right? We wouldn't treat people if we didn't think we were helping them. And explaining what's out there and why we think treating people is a good idea. And there's a lot of people being helped because of that. I think once we talk about these things, I think we can minimize those barriers. And I think we've done a lot, but I certainly a lot more to do. And we have to keep pushing every day.
Exactly. We just have to keep pushing. Thank you so much for joining me and giving me insight into everything about accessing care in rural communities. I hope you have a wonderful evening.
I appreciate it. Thanks for having me
Yeah.
again. And thank you for your listeners who actually took the time we're here for them. And we are, as you said, Anna Maria, we are a community and we are part
Hmm.
of the community. And so we're here to help each other. So that's what we want, and we'll keep pushing it together.
Absolutely. Thanks again.